Hey, everybody. Sorry, we're just getting set up here. So we have an interesting case. I'm with Dr. Shilo and Shashi. So Shashi, you want to introduce the case?
Yeah. So today we're doing a case of bilateral renal vein and IVC thrombectomy. Next slide. So the patient's a 31-year-old female with a history of high blood pressure who was actually undergoing outpatient workup for nephrotic syndrome and worsening bilateral lower extremity edema. She was found to be anemic on labs with hemoglobin 5.6 and was sent to the ED for further workup. During her hospital course, she became acutely short of breath and developed pleuritic chest pain. Other histories is only notable for family history of lupus. Next slide. On exam, on admission, she had some mild periportal edema. She was tachy to low 100s. She had mild abdominal tenderness in all four quadrants, and she had 3+ pitting edema to bilateral lower extremities to the level of the knee.
She's bucking.
On labs, it was notable for hemoglobin of 5.8, and then her creatinine on initial labs was only slightly elevated to 1.06, but during admission, it went all the way up to 2.25. Next slide. They ordered a CT abdomen pelvis and CT of the chest. The CT abdomen pelvis demonstrated bilateral renal vein thrombosis extending into the IVC. And then on CT of the chest, she had segmental and subsegmental PEs on the right. They also got lower extremity Dopplers, which were negative for DVT. We got an echo just given the PEs, and that showed an EF of 60% and normal right ventricular heart motion. So next slide, yep, right. So our plan for today is we got right jugular and femoral vein access, and we're planning on doing bilateral renal vein and IVC thrombectomy with central protection using the Protrieve to prevent pulmonary emboli.
All right, so we have an interesting case here, basically bilateral renal vein thrombosis with thrombectomy is planned here. I'm kind of interested in the panel, what would other people be doing here? What we've elected to do is put up the Protrieve sheath where we can see on the screen that we have protection there to treat the rising creatinine, and obviously going into the cave, we'll be worrying about further embolus. But we've done a lot of these different cases in different ways, half open wall stents, discs up for protection. Fair. So just from the panel, curious on other people's thoughts how they would have set this up. I'm pretty sure most people wouldn't just AC in a suprarenal filter.
Well, you could consider a Gunther tulip and leave it on the actual device rather than pressing the button, so it remains a temporary filter, and you don't have to go retrieve it.
Hey Dan, it's Minhaj. I actually usually deploy a wall stent and put a 24mm partially deployed wall stent. And you can actually make it bigger and leave it on the wire, and then do your thing.
Right. You just don't go past the point of no return. Yeah.
I was going to say the next thing was discs. I would probably deploy the Inari discs and kind of leave them in the Kiva.
Yeah, the advantage of this is obviously you can work through it, right? So you don't have to have a second access, so you can just work right through the sheath. And if something gets stuck in the basket, you can theoretically just suck back on the basket. You're on the sheath, right? Because it is sort of the same sort of setup.
Yeah, so in setting this up, we thought this would be an elegant solution to have protection, works entirely through this sheath. We have an 8 French axis in the groin, and we have IVUS set up, if that'll be helpful for us.
Yep. And then, so right now we're just trying to get into the left renal vein, or right renal vein, or any of the renal veins at this point, to sort of orient the 20 French FlowTriever catheter
you want to load this up?
To the right spot.
And actually, in the interim, we can just show, since we're already inside, who's over there right now?
Oliver.
Hey, Oliver?
Can you show the...
You want to show that off?
Yeah, so we're going to show you how the Protrieve sheath works while we try to get into the left.
Stand behind Elio, I guess.
No, he's okay. He doesn't need a gun.
Right.
No, lead.
Oh, yeah. He needs lead. I'll stand here. Yeah. Yeah.
Pull the wire out. Give me the Benson.
Mm-hmm.
So yeah, so basically you just sort of pull back on these two little handles there. You can't, sorry, we're
no, here.
Good. And yeah. Yeah, no, right here. Pull back. And you can see this thing sort of nitinol cage opens up. Just turn it vertical so you can see.
What's the largest diameter of that?
What's the largest diameter?
It goes up to 33. Yeah.
17 to 30 millimeters. And then it's recapturable, so you don't have to like drag this back out. So you can just slide it back forward. You can see it just sort of recaptures. So you can recapture and reposition it without having to take it in and out. The thing.
And so what if there's a lot of thrombus that's stuck in that? It looks like there's an aspiration port as well.
Yeah, so you can whoosh on the side, just using the standard syringe you would for any of the FlowTriever devices. And obviously, once you have a capture, there's an option to just go from the groin and do whatever else you would do with aspiration.
I think this is off-label, but it allows for 16 French devices to go through it. For example, your forceps. That's off-label.
Yeah. So that's sort of the idea. Do you want the stiff glide?
Yeah, we might go with that.
And so it allows a T16 to go through it also, or does it? That's the
T20. It'll accommodate up to a T20.
Yeah, you can put the T20, the T16. You could theoretically just put the discs if you wanted to, but basically anything 20 French and below, right? Is it open there?
So just a point of interest for me, at least, is what are some thoughts about why this patient has bilateral renal vein thrombus? If it was unilateral, we'd be thinking about a RCC, but so I think the patient had a history of lupus. Is that sort of the going thought?
Yeah, so this is a patient probably with a newly diagnosed, rheumatoid over this, probably lupus, and that's kind of an ongoing workup that's going on right now. Her presentation was nephrotic syndrome. The suspicion is lupus nephritis, and that's kind of the ongoing workup that's happening right now.
I think these patients also have a higher chance of having antiphospholipid antibody syndrome as well.
Yes.
Yeah, that's all that workup's pending still. There you go. Is that down the gonadal?
Yeah, it's going down the gonadal.
All right.
You want to just try the stiff?
Yeah, we can try to use the stiff glide. I mean, I think the better part of valor might just be to do the pulse from the IVC, to be honest with you. It's all hanging out there and see where we get. But if we can do it from here, that would be great.
Oh, stiff hand flap.
The 1cm flap and flap.
So Dan, it looks like you already also have access from the femoral vein, right? And is that your IVUS parked in there?
Yeah, so we have an 8 French sheath. We took some gentle pictures, and we have the IVUS up there to support us and to take cool pictures of a whoosh. Should we so desire it?
Image?
Can you guys see it up there, Mona? The IVUS?
No, just your fluoro images. Now we're looking at the IVUS.
Okay.
So this is this is going above the clot, and now coming back down.
Good. Go. I'm gonna follow.
You'll see the clot come in eventually. Yep, there's the clot. You can see kind of floating in the IVC.
We'll do some wire, push wire. All right. Then we'll just do it from there. It's fine.
Then we're kind of below where it's open.
That's all right.
So the idea is just obviously we can watch this clot kind of
load up the T20.
Kind of go by without having to constantly do runs, right?
What kind of anticoagulation are you guys doing for this patient?
So right now she's on full dose heparin. She's been on heparin for a few days, for a day or two now. You want to take out the 8 French sheath?
Yeah. Is there another piece that goes here?
Do you measure ACTs during the procedure?
If she was on a new ACE heparin, I think we would, but she's been stable on her heparin drip for a while now, so we're not going to constantly measure ACTs. But yeah, it is a consideration.
No wire?
Mm-hmm.
So literally, if you go right above the, that's me, yeah. If you go right above the IVUS catheter, right?
Yep.
Here, I got it. You want to? Got the device? Right there.
So we're not looking at your X-ray images here. We're just looking at your IVUS images. Are you putting?
Can you go back to fluoro, please?
Yeah. So let me know when you can see X-ray now.
We see it now.
Okay, so basically what we have right now, we have the protrude from above, and you can see the disc. We have the T20 through it. That's parked about 3 centimeters below it and just above the IVUS. And from below, you can see the IVUS and the wire that's through that. And we've done a whoosh at the moment.
No, we haven't done it whoosh. I haven't whooshed it yet.
We've done a pull, and we're about to whoosh it.
All right, so
Go for it.
Here goes nothing. So we got something.
Do you plan to use
We'll just be a little patient here.
the blood saver
So go ahead.
device?
We can, but we're hoping we don't have to do that many pulls. This is always fun, right? Just waiting for the clot to come in. See anything in here? I'm gonna push the IVUS up a little bit just to see, or come down.
So what is, for people in the panel doing these, when you encounter this situation where you're probably up against clot and you're very, very slowly filling, do people like to double whoosh, give it more time, slowly pull back if you're addressing cable clot?
All of the above.
All of the above. If you see if you see the IVC collapsing on the IVUS, then you can you're up against something and probably readjust.
Yeah, no, the IVC isn't collapsing.
No.
I think the problem with T20 is that you are unable to put the T16 through the T20 because of length issues. Is that right? I think you can put the T16 through the 24, but the T20 is typically a longer catheter, and you won't have as much of a catheter length out with the T16.
Just pull back and see.
Yeah, that's what I'm doing.
Oh, there it goes. There it gave. So I think it's just corking, or it's like really stuck. Oh, thanks.
Yeah, so in a perfect world, we would obviously have the T24 through here, but with the this outer diameter being
We're getting some
26 already, that would be a very large neck sheath.
So we're getting some stuff. It looks like, oh man, this is a lot more.
Your IVUS image looks clean.
No, I moved it, but
That's why it still looks clean.
we see.
That's advanced technique right there.
I think you need to come down to there, right? Okay, perfect. Thanks.
All right. You want to do a run real quick?
Oh, okay. Yeah, this looks a lot more like tissue than.
Yeah.
Yeah.
You guys ever send that to pathology?
We probably should.
Based on its appearance here, yeah.
Okay.
I don't know if you're going to be able to do that around the IVUS. All right. Ready?
Yeah, it's still there.
Still there? Okay. All right, so I'm going to pull back a little bit. Give it a little check here. All right.
It's corked.
I haven't. It is now.
But you don't know if you have it, right? Like, because you pressed the button, so you lost all the suction.
I didn't push it.
Oh, okay. Oh, it's coming. You can see it.
Let us know if you want us to do a talk over here and come back to you. Also,
No, it's coming. I can see it in the. It's whatever's in there. It's coming out. You can see it in the tubing.
Moving very, very slowly in the tubing.
Yeah.
Kind of this white plaque.
I think now our suction's gone, right?
Okay.
Or maybe.
A little bit more.
I think if it's taking a long time, in this case, I would probably put discs through the T20 and try to grab more of the clot that way too.
Yeah. Yeah. No, that's a good idea.
how often have you found that to be helpful?
I typically just go with a T24. So I usually put a T24 and T16 through and just get it all. I have not used the protrude device yet. So in my situation, I've just been able to get it through large bore thrombectomy. But if it was difficult, then I would try and, kind of clear the catheter. It's sort of working not only to pull the clot towards you, but also to keep the catheter clear. So it's just, an adjunct
But
device.
it might just come off. Mm-hmm. I think we should do one more whoosh and then I'll pull it out with the suction on.
With the cable thrombectomies, I tend to I would say, do about 5 to 9 passes to get most of the thrombus out. I also tend to use a flow saver device. I would say that somewhere halfway in retrieving the 60 cc's of blood, the filter will stop working because you've drawn too much air or something like that, but you still end up giving half of that blood back. So, your EBL is typically around 250 or less.
Has anybody studied whether the blood that's given back is worthy of being given back?
I think their own study shows that there is no hemolysis up to 30 times, supposedly. But I don't know how accurate
Just run and then see.
that is.
Or you think you got? I didn't see any clot there. Did you?
Huh?
I didn't see much clot. Yeah.
I think it would be interesting to look at all the different devices and see how much
Should we get apnea for a second?
actual hemolysis there is. Even we know it with angiojet,
Ready?
but even all the other devices would be interesting.
It's still.
You can breathe.
You're clearing some of it now. It's sort
Yeah,
of.
so we're clearing some of it, but clearly the dominant burden is still there. This is kind of the white plaquish material. We're getting more of that out. So we're getting it out, but not very effectively at all.
So if you guys want to go, as sort of watching us just sit here and do multiple suctions, if you guys want to do a talk and then maybe come back a little bit later.
Okay, great.
Right.
So in the interim, we put the discs down through the T20. I don't know if we have a shot of it, but in essence, what we were doing is we went down, we deployed them at the level of the clot, and then we pulled back into the T20. So far, all of our pulls have been through the T20, not through the actual protrieve sheath, which, as you saw, also has a side port. What we got, if we can aim the camera over here, is more of this chronic, and then also we did a shot to see what was in the protrieve sheath, which Raul is going to put up. You can see there's some small filling defects on one of these shots, which when we pulled the T20 back, yeah, right there, basically to like the ostium of the sheath, the tip of the sheath, we did a pull and we got more of this type of material. So we can see within the cava, most of the burden there is gone. Obviously, given its appearance, we're not worried about, large clot embolization. This is not the soft acute clot that we're all familiar with in the acute setting.
And then we can show you the IVUS. If you can go to the IVUS image.
Yeah.
Okay, perfect. So this is actually above the level of the clot. And I'm just going to pull down slowly.
I don't think they can see the IVUS yet. Hang on.
Yeah, they can see the.
Yeah, we can see it.
You can see it? Okay.
Yeah. And you can see sort of the majority of the clot. That was sort of where the renal veins were. And she's a little volume down, but otherwise that was there. So like all that stuff that was floating in the IVC that you guys saw before looks like it's gone. And so I think at this point, I'm not sure if it's worthwhile to start chasing the stuff in the left renal vein. Her kidney function's fine. I don't know unless you guys feel differently.
So what do you guys think made the difference between what we saw initially and your final result here? What was the key? Was it just doing multiple passes, or do you think the discs actually were the...
So
No,
the discs helped.
Yeah,
I
the
think
discs definitely help. I mean, given the appearance of this clot, letting the disc dwell for 60 seconds and then kind of pulling back was really got a lot more of the clot out.
But it is definitely a lot more organized and chronic than we were sort of expecting. We, given her, sort of more or less acute presentation, we thought it was going to be more acute clot, but this is way more chronic stuff coming out of here. So we'll send it for pathology just to make sure, but it feels like sort of that fibrous clot stuff. But
What size discs did you guys use?
we used the biggest one. So these ones go up to about 25 millimeters. And we sort of just planted them low in the IVC and just sort of scraped back slowly to see if we can free some of the stuff that's against the wall. Yeah.
Can I make 2 comments? One is I spoke incorrectly earlier.
Sure.
In their bench testing, this is word from Inari, in their bench testing, they used the flow saver and basically did 68 whooshes or 8 passes through the flow saver of 60 cc's of blood and saw less than 0.1% of hemolysis. So I hope that answers your questions about the hemolysis. And as far as the discs, I think the older generation of discs kind of is nice in a sense that it can serve as a protective mechanism if you're already going to open up the FlowTriever kit and then the discs. The newer generation, which is the bold, which is a little bit stiffer, can really help get some of the subacute the chronic stuff because it's
yeah, I think, but the newer disc, from my understanding, I don't think it goes as big. It's not up to 25, but I do like the fact that it's a singular disc as opposed to the 3, because you need a lot of length to land it, right? So here in the IVC, obviously we have a lot of space, but if we were to try to do this in, say we were going to try to go after the renal vein, I think it would be very difficult to get the discs to land and sit. These discs, at least.
And did you guys scan her legs? I forgot that part of it. Did she have anything from the common femoral down?
She didn't have
Dopplers were negative.
Her Dopplers were negative for anything acute there.
So do you think that her acute pulmonary embolism was embolus of this chronic material, or do you think it was an acute thrombosis on top of this chronic stuff that made its way up? I know it's an impossible question.
That's a good question.
Now seeing
it's
what
an impossible question. If I were to guess, I would say she probably had this chronic stuff that sort of grew out of her renal vein, and once it hit the IVC, she formed some acute clot on it, and then that shot to the lungs. But without actually trying to go after the stuff in the lungs and getting it out to see what it looks like, I don't see how we'd ever figure it out. Yeah.
Remind me what her echo.
But, I mean, at that point,
what her echo showed in terms.
Her echo was essentially normal.
Her echo was normal. So she didn't have any RV strain or anything like that. So
this peripheral edema, periorbital stuff, anasarca is likely more related to her underlying intrinsic renal disease than anything else, not from any kind of obstructive venous issue.
I mean, if this is truly chronic thrombus, it's a very unusual presentation of it. Starting off in the renal veins, heading into the IVC and caking up there. It's just very, very weird. I mean, this is where, to Minaj's point earlier, looking for some zebras might be worth it, because it's an unusual presentation of thrombosis with totally clean lower extremities.
We've seen it a couple of times. We've seen it actually, oddly, in a couple of cirrhotic patients where they've had this sort of like chronic clot sitting in the IVC for just sort of floating around. But yeah, I agree. It's not not a common presentation for this. And
especially with the nephrotic syndrome, I mean, one of the etiologies is obviously renal vein thrombosis, and whether, obviously she has lupus too, so you have a couple of factors, but you wonder if that was actually an initiating factor for the nephrotic syndrome in the first place and was, a worsening of her lupus. I don't know. I'm starting to talk like a medicine doc, which is dangerous. But
exactly. We need Daniela to be there to help us sort this out.
Do you guys think
that was her initial presentation. It was not for the actual PEDVT. And then during her hospital stay, after a few days of presentation, she had that, that symptomatic shortness of breath, dyspnea. She did have a baby trope at that time, which immediately downtrended, and she did have a slight increase in her oxygen requirements. So something definitely did happen. There was an embolus at that time. But in terms of what exactly it was, the chronicity of it, again, without actually seeing it, we couldn't really say.
Sorry, Minaj, go ahead.
I was just wondering, did you guys get the sort of the amount of thrombus that you expected? Because on the IVUS images, it looked like there was more, definitely on the pre-CT. So I'm just trying to figure out, because
it looked like more. So I think a lot of it sort of, some of it came out in chunks and a lot of it just fragmented. Yeah. So there's actually some stuff, you can't really see it, but there's like little pieces on the discs. I think some of it just literally just fell apart, disintegrated.
Great. So what are the next steps for you?
It's always surprising though. It always looks huge. It also always looks huge on the imaging. And when you actually get it out, I'm always a little disappointed. You expect to get this massive chunk of clot, and it's
What are the next steps for her in her care?
I mean, definitely, further workup, the rheumatological workup, her lupus. We're going to track her creatinine. I don't think mechanical aspiration or removing more clot here in the cava would really benefit her. And so we'll just see how she does from that standpoint.
Yeah, so basically anticoagulation and then follow her kidney function. Yeah. Any other questions?
I would just send the clot and specifically ask for evaluation of looking for all the different weird things in it.
There's a question from the audience.
Exactly.
It's actually not a question, it's a comment. Have you guys entertained the thought that the anasarca is probably a part of her nephrotic syndrome? And nephrotic syndrome is known to predispose to DVT, including renal vein thrombosis. So it's actually an effect and not a cause of what's happening. I'm a medicine doctor.
Yeah, so that's sort of what we think, is that the nephrotic syndrome, it's sort of the chicken and the egg thing, right? Does the renal vein thrombosis cause the nephrotic syndrome, or does the nephrotic syndrome cause the renal vein thrombosis? But it's all tied together. We think that all the edema and stuff is from the nephrotic syndrome. The reason to go after the clot was the
the clot wasn't significant in my view, in my mind, to cause severe bilateral edema, right? We
didn't know. We didn't think the clot was the cause of her swelling, right? We think the cause of her swelling and anasarca is related to her nephrotic syndrome. The reason for going after the clot was because it's basically a nidus. It's floating in the IVC and acting like a nidus. So we were worried that she already had one symptomatic PE.
So putting her on AC wouldn't have been enough?
So she was on AC. She's been on AC for a few days. Actually, she had her clot theoretically. She had her PE on AC. So.
Okay. Oh, I see.
And I also think that, this is one of those cases where you may want to consider thrombus removal because of the higher risk for, you didn't know ahead of time that this was chronic thrombus. You only found that out intraoperatively. Yeah. And I do think that, overall, it's a hard thing to study, but thrombus in the IVC, in spite of anticoagulation, may be an indication for additional thrombus removal.
Okay. All right. Thank you.
Perfect. So if there are no other questions, then I think we are done for this case. And thank you, everyone. I think there's going to be possibly one more case later on, and we'll just see you guys later.
Great case, guys. Thank you.
Of course.
Thank you.